Hello and welcome to the Rural Doctors Programme. I'm Jerry Gannon. Thanks for your company. Tonight we return to the issue of diabetes. We'll visit Royal Perth to discuss the management and treatment of the diabetic foot, and we'll talk to Lindsay France from the Diabetes and Endocrine Health Network about the diabetes model of care. We'll also be taking a closer look at the emergence of type 2 diabetes in younger people, and we'll also look at type 1. And to help us do that, we have Dr. Olga Ward. Welcome along, Olga.
Thanks, Jerry.
We're also joined by two of the authors of the recently released Type 2 Diabetes in Children and Adolescents Model of Care and Clinical Practice Guidelines for Western Australia from Princess Margaret Hospital, Paediatric Endocrinologist Dr. Liz Davis. Welcome along, Liz.
Thanks, Jerry.
And we're also joined by diabetes nurse practitioner and educator Mark Shah. Welcome along, Mark.
Hi, thank you.
Now, how prevalent is type 2 diabetes in younger people, Liz?
It's a good question. We don't really know. We know that it's getting much more common. So every year we're seeing more and more kids with type 2 diabetes. We'd have, what, 60 or...
At the moment we've had about 50 to 60 kids any one time.
That we know of in WA. And the problem with type 2 diabetes is you can live with it for quite a long time and not know. It's not like type 1 diabetes, so that when you get it, you get sick and you come to hospital. So there's probably a lot of kids out there, I think, with type 2 diabetes. There's certainly some kids out there with type 2 diabetes who we don't know about.
Children up to 18?
Well, yeah, or probably 16, really.
16.
We at PMH we'd see really through to 16.
And are we talking about lifestyle reasons as being the common factor here?
Yeah. There's a couple of risk things that predispose you to getting type 2 diabetes. So being Indigenous, which is a big thing in WA because we have a big Indigenous population, is definitely a significant risk factor, isn't it, Mark? Probably over half of our kids will be Indigenous.
So of the risk factors, ethnicity is one of them, of course, and Aboriginal kids have a high risk in their family. Carrying extra weight, particularly around the abdomen.
And when you're talking about frank diabetes in these children, aren't you? Not just insulin resistance, which I'm presuming is much more prevalent in overweight and obese children.
Yeah, absolutely. So insulin resistance, it's actually, people have spent, there's papers and all sorts of discussion about how do you define insulin resistance or insulin sensitivity, because we don't really have a cut-off, but we know insulin resistance, the syndrome of probably relatively high insulin levels. It's really a picture of the metabolic syndrome, usually associated with hypertension, abnormal lipids. And we see that.
And of course, these aren't things that we measure routinely in small kids.
No, we don't measure them routinely, and it's hard to know what the cutoff is that's significant, I suppose, particularly with the insulin level. But we know amongst our population of obese adolescents that insulin resistance is quite high, and we frequently do oral glucose tolerance tests as part of their assessment. And a number of our kids with type 2 diabetes have come to us that way with actually frank diabetes on their oral glucose tolerance test.
So how many kids out of the obese population, what percentage would actually be exhibiting frank diabetes?
Well, that's a very hard question to know, obviously.
Out of your lot,
well, we've looked at the rate of diabetes, the incidence of diabetes per year over the last 20 years, close to 20 years now. And the incidence in non-Aboriginal kids is reasonably static, or it's slightly increased, but the incidence in Aboriginal population is markedly increased over the years.
Is that because you're measuring it more, or is there some factor that's making Indigenous kids even more at risk now? Well,
there's probably two factors. One is probably we're looking at it more often, but particularly general practitioners and community nurses and other people are obviously looking for it more often, so we're seeing more of it. There's more community awareness. And thirdly, there is more of it because I think there's an increased rate of obesity and overweight in that population. So just thinking about the general Indigenous kids that are in a general practice population, when would you start screening them or starting to be suspicious, and how often would you go about screening them, given that they're not really very keen on glucose tolerance tests? Well, I guess we haven't really addressed the cut-off, if you like, of screening. But I think if you look at their family history, particularly diabetes in the parents, and also, like I said, if they're overweight, and particularly also there's other sort of markers of insulin resistance that we tend to look for, such as this a darkening or thickening of the skin around the neck. It's called acanthosis nigricans. And so we know that's a very highly sensitive indicator of insulin resistance.
So if we see that, and we teach that to our, the nurses that we visit, or if we visit in the rural areas and the fellows, if you see acanthosis nigricans, you should screen that child. And they won't necessarily have diabetes, but pretty high chance they're going to have insulin resistance, and then you know that that child should be monitored regularly for the development of diabetes, but even more importantly, we can start to put in some lifestyle changes in that family, you know, and encourage some lifestyle changes in the hope that we could halt or maybe even stop the progression that we know they're at high risk of to type 2 diabetes.
That's what I wanted to ask you. If you detect it at that stage, it is reversible?
The risk of diabetes?
Yes.
I think the general understanding is that, you know, if you're an adolescent and you've become insulin resistant or close to getting diabetes, you're on that pathway for the rest of your life. You are always going to be more at risk of developing diabetes than somebody else who didn't get to that stage in adolescence. Right. But it can be avoided, so that there's no doubt. So we've had kids with type 2 present with type 2 diabetes who, not many, but we've definitely had some who actually adopt fully the lifestyle changes, because it's very difficult. Families find it very difficult to make those changes. And as they lose weight, they can actually will become non-diabetic and come off their treatment. And
when we look at Indigenous kids in particular, what sort of lifestyle changes are we talking about? Because for many of them, the basic nutrition level is not all that flash.
Well, I suppose the message is the same across the Indigenous and the Caucasian kids. The strong messages are exactly what you said, to try and encourage a more healthy nutrition and diet. So a lot of these kids miss brekkie. They have a high intake of high caloric dense foods, you know, cool drinks, pies,
chippies,
rubbish,
junk food basically.
Yeah, not fruit, not vegetables, not fibre, you know, and so we try and encourage that move to healthy eating. And some communities have actually put in significant efforts in this area and have sort of provide now breakfast at school and education about food and
building their own gardens and things like that.
Yeah, I know that there are a lot of school vegetable gardens, and thank goodness there are, because vegetables particularly almost impossible to afford.
Exactly.
At country shops.
And in the rural Aboriginal Indigenous communities, the shops, the vegetables and things can be prohibitively expensive, and that's one of
and about the 2 weeks old by the time they've got there.
The family's site for not, you know, particularly doing, taking on the healthy eating to the full extent. And the exercise is also important. So some of the communities have taken on board programs, and there's a group called the UFPA who've been involved in a number of communities and helped promote this, regular exercise programs in the school, building up football teams, people living in the community to encourage kids to do after school activity, get everyone out walking, simple things. And the other thing in the Indigenous communities, which we can't treat as such, but we can give advice on, is that young Aboriginal women getting pregnant who have either gestational diabetes or pre-diabetes or diabetes before they fall pregnant, their kids seem to be at increased risk of insulin resistance and diabetes, independent of their own lifestyle, but just probably because of genetic and that intrauterine environment. So there's a vicious or a worrying cycle there that perhaps may lead to increased predisposition to diabetes.
So that'll be something that the GPs now will flag is really gestational diabetes, child of.
Yeah, to watch them and follow them.
Yes.
There is some work that's come out showing perhaps the healthy BMI of an Indigenous person is actually lower than the healthy BMI of a Caucasian person. So it is something that GPs could take on board, you know, when they're measuring BMIs, that in an Indigenous person you might start to express some concern at a BMI that's just, you know, BMIs are done in kilograms per metre squared. So, you know, instead of 25, you might say 22 or 23. There is some evidence to suggest that. A lot of people have suggested perhaps that would be from a health point of view, so that perhaps Aboriginal people tend to put on weight centrally as well.
So that's a very important risk.
Yeah, and so perhaps by just keeping that BMI down a bit, you can decrease the risk of that central weight.
I've always thought that BMI wasn't all that useful in children.
Well,
still as a measurement, you know?
Yeah.
Still useful and still the same range, or do we just simply look at the centile chart and make sure they're running on the line?
That's the problem. The BMI of kids changes over time. So, you know, they're big and chubby when they're toddlers, and then they shoot up for a few years, and then they don't grow for a few years, and then they go through puberty. So if you're going to do the BMI of a child, you have to calculate it as within 1 kilogram per metre squared.
They're at as well.
But then you have to plot them on a BMI chart for children, which varies. So at one age, over obesity, you know, can be just 18 or 19 kilograms per metre squared at a certain age for a kid. So it's very different to adults, you know, where the cutoff is over 30.
So now most of those, just the normal centile chart graphs are in most of the medical programs like Medical Director and Locum and MedTech. But are they suitable to plot Indigenous kids, or should we be looking at maybe sitting them below the 50th centile?
I don't know. Yeah, that's right. I don't know if Medical Direct give you BMI Z score. So we can
it's
actually
usually
calculate
just
the
weights and heights.
Exactly. But you know what? If they're on the chart, they're not too bad. It's the ones that when you pull up them on the weight chart and they're way up here, or there's no room on the chart, even because of the box on the chart to even put them. Where you've got to raise your concern. So I think they're on the chart between the 3rd and the 97th. They're the ones you're.
Less
concern is, that's right. So whether on the 50th, the 75th or 90th probably is not as important as when the ones that are way up.
Liz, obesity is one of the growing issues in Australia, not just Australia, but the world. The US has got a particular issue with it. But among children, it's starting to become an issue. And as you said, among the broader population, it's an issue. But among the Indigenous population, where do you rank this? Diabetes, obesity, and all of these attendant factors as a health risk for Indigenous communities?
Oh, absolutely. Well, we rank it as number 1 because that's the work we do. But in fact, if you look at the figures and cause of death, and in some recent figures that came out, national figures that came out from the ABS, I think, and it's in the latest sort of Indigenous report that came out nationally, the life expectancy of Indigenous people was about 19 years less than Caucasian people, so that's just horrendous. And the leading causes of death were cardiovascular and diabetes, and the two are so intertwined. It's quite hard. I mean, I'm sure they were able to tease them up, but it's very difficult to tease them up.
So it's number 1, basically.
So it's right up there.
And with smoking.
Yeah.
Well, the smoking rates are going down.
That whole sort of risk package that fits together.
Could you just for a minute talk about other risk factors for diabetes in kids and teens that aren't to do with being Indigenous? And what about kids with things like Down syndrome, or the little teenagers that kind of go on yo-yo diets or become bulimic? Are they in a particular risk category?
Well, I don't know of any risk at all with Down syndrome, and also maybe children on different diets. I think that the standards of the risk factors obviously are even for non-Aboriginal kids obviously is increased BMI. And a strong family history of
And so
of
Down
diabetes.
syndrome kids, although they tend to be centrally obese, aren't more likely to become diabetic?
We don't see many of them with diabetes, but actually if you look in the text, and historically they probably have a slightly higher increase, but it probably doesn't, we don't see that reflect our clinic, because it's still, we're only still talking a small number of kids with type 2 diabetes. It's the critical thing, I suppose, and it's got so much attention, is that, just as you said, obesity is going up like this.
And the trend.
And we know they're linked, and we're certainly seeing, we've got graphs about type 2 diabetes over the year, the presentation is going up like this as well. So we're sort of, although we're talking small numbers, and we know that some kids are at risk of diabetes, you're absolutely right. So there are kids with certain medical conditions, usually quite rare, that we know it's on the list of increased risk when we see them. And there's a thought that perhaps girls with Turner syndrome have an increased risk of diabetes, but again, it's just down the bottom of the list. Exactly, they're really small numbers. So when we see these kids, we think about it.
And kids with asthma or whatever who are taking a lot of steroids,
well,
do they just precipitate off into frank diabetes during the steroids, or do they stay there?
We know that, that's absolutely right. Prednisolone is quite commonly used now, 3 or 4 days of it. And some kids do get diabetes during that time, and they present to us, and we monitor them, and you're absolutely right. While they're taking the steroids, they do. Most of those kids, when they stop the steroids, it goes away. Some of those kids we know have got whatever it is, an insulin resistance level, which the threshold is different, so they're probably more at risk of diabetes over time. But there's not a lot of data tracking there, but we always feel they're probably at higher risk than someone who takes steroids and doesn't get diabetes.
And of course you've also got to be very careful that you're not categorising someone with the type 2 or type 1 diabetes, and actually assess them properly and ensure that they're not dealing with type 1 diabetes, or for that matter not dealing with type 2 diabetes.
So what's your advice to doctors who are talking to young kids about what they eat for breakfast?
Well, first of all, neither of us are dietitians.
Understandably, but...
And probably the advice for
Number one, eat breakfast.
Eat breakfast.
So eat anything?
Well, ideally, sure, they're going to sit down and have, Wheat Bix or something with muesli and cut up fruit, but just how many adults do that either? So I think it's just a general identification of the importance of having breakfast. And in fact, I find even just having breakfast quite useful for the overweight girls, overweight kids, but particularly girls. There's a high incidence of missing brekkie, as there is in the general community, but they think it'll help them lose weight. And there's actually some suggestion that kids or women who miss brekkie probably increase their risk, are more gain weight and find it harder to lose weight. So even just getting them to have breakfast is good. Obviously, you encourage them to have something that tastes good. They're not going to have it otherwise. So you like to put yogurt on what they like, or to cut fruit up and put it on it, and to try and get some fibre in there.
I think the message really comes from the parents. And if the GP can really engage with the parents, and you know, if the parents see the children see their parents eating breakfast, eating appropriate breakfast, they're more likely to you know.
And
there's
a lot of parents don't. They grab a cup of coffee and they're out the door, you know,
Yeah,
and then people don't have brekkie together and. Like
those days are well and truly gone, Liz. You'd be too young to remember those days,
Oh,
Liz.
get out of here. So it's really difficult, and it's just, I mean, I think GPs are probably, this probably makes up a huge amount of what you do now in general practice is talking about healthy lifestyle. Whatever you see people for, whether they're planning a pregnancy, whether they're in middle age, whether they've had cardiovascular symptoms, everybody's trying to sell that message. And like they were with anti-smoking, billions of dollars and how many millions of hours of talking when you're trying to promote that, and it takes a long time, and now we're starting to see the trends towards improvement. So
Now with your kids and your adolescents, when you're talking to them, I mean, we're talking lifestyle. Is that the whole answer, or do they actually get medication as well?
Yes, indeed.
And what do you give kids with type 2 diabetes?
Well, we've got a guideline obviously now that we've established, and it's obviously spelled out in there about the treatment guidelines and the appropriate management. And essentially, in many ways, it's no different to adults for type 2 diabetes, where lifestyle is a cornerstone.
Lifestyle, start them on metformin.
Indeed, yes. So metformin is the first line of therapy. It is actually the only tablet medication that's actually indicated for children.
Okay, so we don't use sulfonylureas in children at all?
We would certainly, and that guideline directs metformin should be the first line of choice, and then we would suggest no charging on sulfonylurea without being certainly seen in a tertiary study and being followed, tertiary centre being followed, you know, in almost a study-like fashion, because they aren't indicated for children. We don't know what the long-term risks are. And we have had a few kids on sulfonylureas and haven't found them particularly useful, but I mean that's only a small.
But our next line of therapy is insulin, and so in various different ways. But often we might choose to use a sulfonylurea for those patients, perhaps where insulin therapy it's not working, or they're not going to take it, those sorts of things.
That's usually a big incentive for lifestyle change if you say you're going on insulin if.
Yeah, we really try not to use it as a threat. I know it's tempting to do that. We do sometimes use the carrot for families that, you know, we sometimes put kids on insulin quite early on. The kids with type 2 who present, you know, with frank diabetes, polyuria, polydipsia, sometimes some ketosis, and a really high HbA1c, we'll sometimes use metformin in the first insulin in the first couple of months to try and get control of that situation and get their blood glucose levels down. Because the longer you've been running with high blood glucose levels, the more insulin resistant you get to a certain extent. So it's quite hard to break that cycle.
If they're ketotic, aren't they a type 1?
Yeah, it's a good question. That's what the textbooks might tell you. But no, if you've got type 2 diabetes, your risk of getting ketosis is less. But you certainly see a number of kids with type 2 who you can have ketoacidosis. We've certainly had a child who presented with type 2 diabetes who was ketoacidotic in ICU.
Probably the risks there increase with type 2 diabetes. Obviously, they may present or they may be asymptomatic for a long time, and their blood glucose levels might actually increase slowly without them actually realising it.
So they're massively insulin resistant, and their pancreas just simply can't keep up.
They get sick or something.
They might get sick. They might get infection. They might get a toe infection, or they might get a thrush. Those sorts of things, and their blood glucose levels rise, and that can actually tip them over into ketosis.
All right. Well, we might take a break from the discussion there and return to it in a bit. Complications from diabetes are the leading cause of preventable amputation, and the solution in a large part is earlier detection and treatment of any problems as they occur. We spoke to Dr. Seng Khee and podiatrist Deborah Schoen and Carol Westphal from Royal Perth Podiatric Clinic about the management of the diabetic foot.
Well, the diabetic foot has can get quite a few complications. In essence, what we're trying to do is preserve the limb, and when there are diabetic foot ulcers, which can lead to deeper infections, and when this is on top of vascular compromise, then we are at risk of people losing their feet. And diabetic foot problems are, in fact, one of the major causes of amputations, non-traumatic amputations in especially younger groups as well. It's the major cause of amputations. Now, to various extents, a lot of these complications, if we detect them earlier, can be, to a way, preventable or prevented. So, yes, in some ways, we could do better. About half the amputations, major amputations in Western Australia are due to or related to diabetes. And when you're looking at minor amputations, so parts of a foot or toes, then it's about 3/4. So diabetes is a major portion of how people sort of develop foot complications, and we could certainly do better there. Yeah.
The first thing that you should always do is get in the practice of looking at every diabetic person's feet at every appointment that they have with you. It's also important for Aboriginal health workers and nurses to do the same thing. The more feet you look at, the more problems you're going to pick up, and you'll pick them up earlier rather than later. Making sure the shoes aren't causing them any problems, looking for any corns, calluses, any ulcers or other lesions on the feet, which could all indicate problems down the track.
And it's really important when we find some of these calluses to actually debride them. Okay, take a scalpel blade, debride them and find out what's underneath, because sometimes we do debride them and we find there's an ulcer underneath, and if the person's got neuropathy, damage to the nerves, they've got no idea.
If you just ask a patient if they have any foot problems, quite often they won't be able to tell you because they don't have the pain sensation.
And probably one of the best screening tools that has been used by general practitioners is using a 10-gram monofilament to detect what we call loss of protective sensation.
If they do have a loss of protective sensation, then they are at a significantly higher risk of ulceration and subsequently amputation.
We've just got to then tell people to check their feet every day, to actually use their eyes and their hands to have a look, because a new pair of shoes, a blister forming, something rubbing, they won't feel it. Something that's gone through the bottom of the shoe or gone into the shoe, they won't feel it. So then we just have to educate them about check your feet every day, to actually turn up your foot and have a look. It doesn't take long, but it saves feet.
They don't realise that they've got a problem with their feet, and that's where GPs and other allied health and Aboriginal health workers can really step in and physically get down, have a look and check the feet for any ulcers, lesions, pressure areas. Simple palpation of the pedal pulses is probably the most easy test to do in the clinical setting. If pulses are not palpable, then you should really consider doing an ABI, which is an ankle brachial index. Basically, do the blood pressure in the arm and the ankle, and you get the ratio. And if the value is indicating ischemia, then you should possibly consider referral to a vascular surgeon.
Once people do develop diabetic foot ulcers, then they do need to be assessed well and given the appropriate management, because the longer these ulcers stay open, then the greater the risk of complications. When you're assessing a foot ulcer, you do need to assess all the factors which are involved into why that ulcer appeared. Otherwise, you're going to have difficulty getting that ulcer to heal, which is what you want to do. That will mean attention to pressure offloading to address the neuropathic cause for that ulcer, addressing vascular status so that you can address any ischemic component which may be contributing to that ulcer, addressing glycemic control, because ultimately poor glycemic control will allow more infections to take hold. The fourth question is to assess for not just surface infection, which is what's going to be usually present in most ulcers, but to assess for deeper infection, which may be delaying the healing of that ulcer. And most important of this is osteomyelitis, or perhaps a deeper subcutaneous abscess. Ulcers can look very innocent on the outside. All you may see is a small hole or a small little ulcer. But sometimes it hides a lot of what's going underneath. So it is important to probe ulcers carefully to see if there's a deeper sinus. And if it does probe to bone, then you have to treat that ulcer very seriously and assume that there's a high chance of osteomyelitis. I'd also recommend a plain film for when assessing ulcers, especially for more chronic ulcers of perhaps longer than just a few weeks duration, because there may already be some osteomyelitis, but very often on the surface you may not be able to assess that very easily. Early on, as long as these factors are sort of addressed and provided the ulcer heals, then there probably isn't a need to send them down to Perth. Now that often requires an appropriate and podiatrist nearby who can actually do a lot of the local care, and with neuropathic ulcers, debriding the ulcer and removing callus and providing appropriate footwear is very important to try to avoid further progression of the ulcer and to sort of enhance healing of the ulcer. So unfortunately, foot ulcers will have can have a number of pathologies, of which neuropathy and vascular supply is important. But in the end, if it is a newly developed ulcer, there probably isn't a need to send them immediately to Perth, as long as you feel comfortable that you can provide the adequate pressure offloading for the neuropathic element, which is contributing to the ulcer, and provided they don't have a major vascular compromise, which is contributing to that ulcer. If you can touch bone, then we usually have to assume that osteomyelitis may be present. And just a plain film X-ray, if that shows any bony changes also, will tell you whether there's a significant deep infection. And if that's the case, then obviously they need to be sent down to Perth. I think vascular sort of compromise is often quite obvious. If there's a significant ischemia of the limb, then they will need to be sent down to Perth. The other sort of situations that I suspect patients may need to be sent down is if the ulcer isn't healing. So despite your best measures with offloading, optimizing vascular supply, optimizing glycemic control, and maybe treating any soft tissue infection, you're confident that that's all happening, but the ulcer isn't healing, then that's the time they also need to be sent to be assessed with us, because if we don't heal that ulcer over the longer period, and the longer it goes with an open wound, then it's just a matter of time before the patient develops a more serious deep infection like osteomyelitis. Now obviously the other situation is that where you feel like, depending on where you are in the rural area, whether you can't provide enough pressure offloading, appropriate footwear, then you're probably going to have to send them to a centre where they can get access to podiatrists who can do those things.
If you don't see well, if diabetes affects your eyes, people can't see, they do something about it. If they have a heart attack, they do something about it. But with feet, when the nerves are affected, they don't hurt. So it's really easy to keep walking around with an ulcer or an infection in your foot and not have to do anything about it. There's not the pain and there's not the limitations. So people can often keep going for a long time before they become really unwell with a diabetic foot and need to be admitted to hospital.
So there's multiple levels by which we are talking about this problem, which of course can be on one hand prevented if we can educate patients better about them and take better care of their feet, and clinicians and allied health staff are all aware of this problem better, in a better way. And on the other hand, once they do develop these ulcers, then there needs to be better assessment and management for them to try to heal these ulcers, because even if there aren't any deep infections developed yet, if we don't heal these ulcers well, then the chance of a deeper infection occurring is actually quite high.
It's definitely, podiatry is a service that is definitely not to the level it could and should be in rural and remote regions. And GPs are obviously in rural areas going to be one of the, basically a one-man band, and that's why it is really falling on their shoulders to pick these problems up early and educate their patients, and I suppose improve their knowledge in relation to the diabetic foot. So
GPs are to various extents variably sort of aware of this complication, but we do think greater screening for these high-risk diabetic foot needs to be done.
Take the shoes off, have a look at every diabetic patient's feet at every occasion they come and see you, touch the feet. get on the phone and speak to a podiatrist or a diabetes specialist at any of the tertiary hospitals. They would always be happy to help you out and guide you in the right direction if you're not sure which way to go.
So the message there, I guess, is to have a look at the feet every time you see your patient. And if you'd like to contact the Royal Perth Podiatry Clinic for advice or support, you can call them on 08 6477 5214. Now back to our discussion, and before we went to the break, Mark, you were mentioning that there is a treatment modality laid down in the care model now. Where do you get access to that?
So that's access through the Department of Health website, and the WA Diabetes, we've actually got our own website, www.diabetes.wa. I can't exactly remember.
Or something like that.
And all the models of care for diabetes are actually in that.
So we'll put that link up on our website.
Yeah, that would be a good idea if you could.
Something else just on top of that diabetes model of care that might be helpful for people to know is, so certainly from a paediatric point of view at PMH, we have someone available every day to take phone calls for advice on kids with type 2. And Mark's particular role really is to be there as a sort of nurse practitioner with expert advice for anybody in the community, whether it be nurses or doctors,
useful to know.
Either trying to investigate or starting treatment or wanting some help with someone they think might have type 2 diabetes. And we're really keen to hear from people if they've got kids who they have diagnosed diabetes and to try and keep an eye on the numbers and resources and be able to help those people and get feedback from them about what extra advice or information would be available to have. So we're really keen to take calls from people who are in that position of seeing kids with type 2 diabetes or considering type 2 diabetes and providing advice.
Yeah. And certainly if we're screening kids, we'll probably be ringing for advice about you know, what to do and how often. And
yeah, certainly. We're really quite sure that there's obviously more children with type 2 diabetes than we actually know of. It's a very important point.
Now, every now and then you'll get a sick kid who'll turn up and they'll be ketotic and you'll think, oh, I wonder if this is DKA. And when you actually do the tests, you'll find that they're massively insulin resistant, but that their fasting insulin levels are really low. So you've got this kind of mixed picture. What's going on there?
So this is a new kid. Well, it could be two things. We certainly, in puberty, anybody gets more insulin resistant. So some of the teenagers who present, so that kid might have type 1 or it might have type 2 diabetes. And actually, when we first get someone who presents in that situation, it usually takes a couple of weeks for us to be, not, you know, we would always say to the parents up front, it may take us a few weeks to get to the bottom of this. Sometimes sort of all the pieces fall into place very quickly and we know in a day or two, we say it's definitely type 1, it's definitely type 2. Sometimes it takes us a few weeks, so we're always up front with the parents in that situation, you know, that it takes us a little while to sort this out. And kids who go through puberty are insulin resistant anyway, so you know, type 1 can present quite insulin resistant and they've had high blood sugars for a long period of time. They can appear to be insulin resistant. Sometimes the pancreas has been working really overtime, so it's been making lots of insulin, and then you get sick or for whatever reason that's tipped them over the edge.
It just packs it in.
It does, and so when we tend to use, in that situation of a sick person, we wouldn't use a fasting insulin as a particularly useful tool. We will do a C-peptide, it's got a longer half-life, so it sort of reflects the situation a little bit better. We do a use as fasting C-peptide when they're diagnosed, and most of our type 1s would have a fasting C-peptide either in the normal or the low range. And most of our type 2s will have a fasting C-peptide in the normal or the high range, but they're just guidelines and it's not always like that.
Of course, these are the kids that we would mostly ship out, but we would also often, you know, take the bloods for initial levels, and then it's very difficult to interpret. You're not quite sure what to tell the parents to expect.
It is very difficult. We use antibodies.
Yeah, that's right. It's important to do the diabetes-specific antibodies to either exclude type 1 diabetes or, you know,
and even then it can be grey because we're now seeing kids with type 2 diabetes who have some antibodies and everyone with type 1 doesn't have antibodies. But so it's always a collection of these things. And actually for us, it's if we're not sure, watching them over the first few weeks, so what happens to their insulin resistance or insulin sensitivity as they're treated, what sort of insulin doses they require, all that helps us come to a clinical feel and the kids we're not sure about. Which probably brings us on to an important point that Mark and I were talking about the other day, and you sort of mentioned the skinny runt. Traditionally in the books, and when you teach people, you know, kids who present with type 1 diabetes are scrawny, they've lost weight, and that's one of the, I suppose, the flags that GPs have always took to mind, polyuria, polydipsia, weight loss. But because of the shift in obesity we're talking about in the community, we're seeing a number of kids with type 1 diabetes who are overweight when they present. So they may have lost 3 or 4 kilos, but when you see them, you may not know that, and sometimes the parents aren't even aware of it. and yet they can have type 1 diabetes. So I think everyone's going to have an open mind now too, that overweight kids are 20% of the community, and they get type 1 diabetes as well. So kids who present now with diabetes are not always wasted and cachectic like the traditional picture.
So the actual weight isn't an important indicator, it's their history.
Yep. Now, one of the things that GPs do a lot, of course, is assist parents to manage. And one of the things that parents like to do is read much alternative literature from health food shops and the Women's Weekly and various other reputable sources. And they'll often come in and say, oh, I'd like to put the child on a zinc supplement or a vitamin C supplement or on some antioxidants to prevent long-term complications of either of their diabeteses. What sort of advice can we give them?
I guess there's not all that much good data about the use of supplements, either improving their diabetes or preventing diabetes in maybe siblings that have got parents with diabetes. To be honest with you, it's not our field of expertise. So. Yeah, not too sure.
That's a good hospital hand pass there.
One thing I think that you have to with that is when people have looked at kids with chronic disease and done surveys, somewhere between 30 to 50% of kids are on complementary and alternative health supplements when you take a specific history or you do a survey, and it's not something we routinely ask every time our kids come to clinic. Because if that works for the parents and they think they're doing something good, I suppose the bottom line is as long as it's doing no harm. So when I say it's not doing any harm, that they're not on mega high doses of something that may be dangerous, or they're not thinking they can replace the kid's treatment, which particularly insulin. A kid with type 1 diabetes will get incredibly sick and be ketoacidotic within a day, most of them within a day or two of not having insulin. So I think from a health care provider, it's really important to try and
so okay for them to have the chromium and the zinc, but they don't stop the insulin.
As long as they go with the other treatments as well, to kind of embrace that. And there are studies out there, sort of fenugreek in the Indian community. There's quite a lot of literature on the use of fenugreek as an insulin resistance, a treatment for insulin resistance. And we've certainly I've certainly had Indian patients who use that as well and claim that they're able to bring their insulin doses down. So I think we have to have an open mind. They probably all have some complementary role. So I think lots of people use them, and as long as it's encouraging patients to be open and honest about what they're taking, then you can work with it.
As you say, do no harm. Do no harm, and
that's the first thing.
There might be something that's deficient.
To embrace if that's what they feel they're doing something, that they believe in, well, to embrace it and try and build it into your treatment regimen so that you're working together on it.
Now, what sort of insulin do you use for your little type 1s? And do you put it in a pump or a pen or
all of the above? So we use various different types of insulin. We use rapid insulins, and we use intermediate and long-acting insulins.
So the rapid insulins are the things like NovoRapid and Humalog.
So Aspart or Humalog. We use those two brands, and we use NPH and
so Aspart's is NovoRapid.
NovoRapid. And so we use Protophane as well, and NPH. Sometimes some children are on a mixed regimen where they have mixed insulin in the morning and a mixed insulin in the evening, and some children are on what we call basal bolus regimen where they might have a rapid insulin for their meals, so 3 injections, perhaps 4 injections of a rapid insulin, and maybe a long-acting insulin such as a Lantus or a Detamir.
So something that will just sit there for 24 hours and give them
in the background.
So there's basically an insulin to suit all occasions, as it were.
In many ways, in many ways it is. And of course there's an insulin pump as well.
So what do you put in the pump?
Again, rapid insulin. So it's either Humalog or NovoRapid.
All right, and that's an implantable device, and the child just dials up the dose, or the mum just dials up the dose. How does it all work?
So they have a little catheter, a little plastic catheter, or Teflon catheter that sits under the skin, and that delivers insulin via a tube connected to the pump, and the pump has a reservoir of about 3 mils of insulin.
And you just connect at the skin, so a lot of people kind of, whoa, it's going to be stuck to me or attached to me all the time, but you just can actually twist and disconnect it at the skin level so the little catheter's set there so they can take it off for baths.
So that they can go to the pool or whatever.
In the pool, that kind of stuff, contact sports, and then click it back on at the end. Some kids actually click it back on at half time if they need a bolus, because some kids go, we're not specifically focused on exercise here, but a lot of kids with diabetes go high after a heavy bout of exercise, so some of them even can click it back on and give them a dose, take it back off.
What's the reason for that?
It's probably related to those kids who really work hard in acute sport with short, sharp sprints. You're not talking about long distance cross-country endurance runs, but the short, sharp, put-it-out sports like
footy
soccer,
or hockey
footy. And they're the kids on the field who are really working hard, not the ones who are just sitting out near the goal and doing nothing, you know, but the ones who are really working hard and pouring out all the adrenaline. And it pushes the glucose level up. As with the kids when they're stressed, it's the same thing. So I think there's a real sort of new awakening in the diabetes field from the medical side, stories that parents have been telling us for a long time. Some kids, when they're stressed, need more insulin. So before exams, family stress, you know, we know kids who've, there's a lot of stress in the family, changes going on, their HbA1c goes up. Sure, sometimes the organisation and the treatment regimen is difficult during those times as well. But there's no doubt the stress, which is probably the same thing, you know, excess adrenaline and steroids being made by the body, creates insulin resistance and the insulin doses need to go up. So it's a little bit similar. But coming back to the, back to the pump, it's fantastic to adjust all those things.
So they'll crank it up maybe and give themselves a bolus at half time. Are they then at really big risk of having a hypo after the exercise? Like, do they have to have a honey sandwich or something as soon as they come off at full time?
So there's a lot of variables when it comes to exercise, and you've illustrated that there are a lot of questions, and many parents, many children struggle, many type 1 diabetes adults struggle, but certainly many hours after exercise there are increased risk of having a hypo, and so we do encourage them to obviously eat at appropriate times and reduce their insulin. The beauty with a pump is that they're able to lower what's called a basal rate, so that they have a background insulin rate that's infusing into the skin, and
to keep it level, to keep them level, basically.
Well, yes,
but you can dial it down. So basically, when they run around and play sport and they push their glucose up, it's because they're emptying their liver. Basically, they just dump it. Well, not all of it, but a lot of the glycogen's being dumped out, and you haven't been able to replace it a lot. So we know it's about 6 to 7 hours after exercise from studies that are done. Seems to be about the peak time that probably the liver's really, you know, run out of stores and needs to be built up. And
what are some of the factors that lead to young people developing type 1 diabetes?
Do you want to answer that question?
Yeah, wish we knew, we don't. But we know it's going up. It's going up at about a rate of 3% every year. And the figures are at about 24, 25 per 100,000 kids get diabetes. It's, I think, probably the second most common chronic disease in childhood.
Wow.
Well, certainly it's up there above childhood cancer. Asthma comes in above, and if you're talking about things like eczema and stuff like that, probably higher. But of the sort of serious chronic, I'm not saying eczema's not serious, but of the sort of serious major medical conditions, asthma's probably up there, and then diabetes. And we don't really know. We know that you've got some genetic risk factors, and some of the HLA things that we can measure in the genetics we know are risk factors. We know there's some spots on the genes that are protective. We know if you have a family history of someone with type 1 diabetes, a mother or a father, your risk is increased, but it's not directly inherited like some conditions. We know if you have a father with diabetes, your risk is higher than if you have a mother with diabetes. It's an autoimmune condition. The beta cells are destroyed. And the reason is why are they destroyed? But it's different.
And
there is a bit of a spectrum of the disease.
Of severity.
Well, between type 1 and diabetes, sometimes it is difficult to sort of categorise someone with type 1 and type 2, because there is a known spectrum with people with type 2 diabetes sometimes having antibodies, and so it is sometimes
with these
difficult.
kids who have type 1 diabetes, and they often develop it quite early on in life. When are we looking at them developing complications, even if they've got really good glycemic control? Like, should we be having them on statins from the age 15 or something?
It's a really difficult question, because our protocol, I suppose, is we have a protocol. You know, we see these kids every 3 months, and we have a screening protocol. So whenever they had diabetes, type 1 diabetes for 5 years, or they hit 12, I think is our cut-off at the moment,
11.
we start to do that year of 11 to 12. Isn't it? We start to screen for protein excretion in the urine, so that microalbuminuria, very small amounts we're screening for. We start to look at their eyes, and we do their lipids, regularly. But the reality is, these kids are already on a lot of medications, and we just don't know the role. We often sit around and talk about, do we put them on a statin, do we not, because it's another medication that they have to take. And we don't really know, I think it's fair to say, the long-term history of the role of the statin. So there is some evidence that statins actually help reduce microalbuminuria as well, sort of the renal disease. And certainly ACE inhibitors are what we use to treat that, and they're used for hypertension. So how early should we treat blood pressure, you know, when it gets to 95th centile? And there are national guidelines coming out and international guidelines. But the reality is in most clinics, in adolescence, which is the time we're talking about where you start to see these things happening, we have so much of a focus on just getting them to take their insulin and to do the simple things. In many cases, we sit around as a group and then we go, actually, we've talked to the family about it, but we really think adding another medication is just going to...
I mean, still...
counterproductive for a teenager.
It's really difficult.
Of course, we know, getting back to the complications and outcomes, we know, of course, that level of glucose control is a very, very potent, important indicator for reducing risk of complications. So, in making sure that people do their blood sugar levels and get appropriate control actually reduces the risk.
And with your little type 2s that are kind of coming through late adolescence, are you looking at the same kind of lipid control things, or would you be a little more proactive in putting them onto statins?
Well, certainly in that group, the family history is really strong for metabolic syndrome, so high hypertension, high lipids. So there's a family
risk. So
risk.
you've got a 15-year-old with a cholesterol of 8, you might actually treat it.
I think at 8 we probably would, although the triglycerides and LDLs, HDLs are really important, as well as the total cholesterol. But it just comes down to whether you think the family are going to give that medication as well, or whether they're just complicating things and making things more difficult. But there's no doubt in the adult literature that managing the hypertension and the lipids, it may be as equally important as the glucose levels. We don't know the answer in kids. Well, not as equally important, but they have an important role, don't they?
Yeah, certainly. Well, certainly I think our level at which we might decide to start a statin or even an ACE inhibitor in someone with type 2 diabetes is much sooner than what we would someone with type 1 diabetes.
And just finally, can you just comment on binge alcohol intake in teenagers and how that affects is that going to shove their sugars way up or just a bit up, or in particularly your type 1s? I think?
Well, it can be it's a very dangerous situation, because one of the problems with alcohol, particularly with maybe a high sugary mixer with it, the blood sugar levels can go quite high, but the alcohol will actually mask hypoglycemia or cause hypoglycemia many hours later. So it's incredibly dangerous.
Bourbon and Diet Coke?
Well, one of the problems with that, of course, is that if they have bourbon and Diet Coke, the alcohol content in the bourbon can actually increase their risk of having hypoglycemia later on.
And we would just like to point out that Dr. Ward is in no way advocating bourbon and Diet Coke as a drink for teenagers.
Any alcohol for children under 18.
The most important factor is for them to obviously monitor their glucose levels when they can, obviously. But
so just be realistic and say, look, check.
If you teach them the principles, exactly what Mark's saying, that the alcohol, this liver here is a big store basically of glucose turned into glycogen that helps protect them. But alcohol actually stops the liver being able to release that glycogen, so it actually interferes with that process. So if you even when they get that understanding, you can tell them, look, if you drink, this is going to happen. You tell their parents that, it just stops it working. Even getting their parents to get up and check them when they get home, they have to understand that process of why the liver doesn't make the glucose. And as soon as they've kind of got that connection, that's what the alcohol does, you can teach them.
They've got to eat.
Right.
They've got to eat.
Well, finally tonight we hear from Lindsay France from the Diabetes and Endocrine Health Network about the diabetes model of care and other resources available through the Health Network.
Well, health networks have been set up for about 4 years now, and the idea was to bring people together, not just the bureaucrats, but to bring people together from outside, from throughout the community, including health professionals, consumers, carers, people in allied health, non-government organisations, to contribute to the policy and planning of the Department of Health. So to give a better voice to people who have a stake in healthcare delivery. The Diabetes and Endocrine Health Network is headed up by a clinical lead. He's an endocrinologist by the name of Dr. David Hurley. Dr. Hurley is a highly experienced endocrinologist in Perth. He has been operating in private practice as well as does sessions at Royal Perth Hospital. The area of delivery of endocrinology services and diabetes services to rural and remote areas is very close to his heart, and as the clinical lead of this network, he's intent on improving that part of healthcare delivery. And it is an opportunity for people who are interested in following the health networks. We can be advocates for addressing health issues, particularly in the area of diabetes and endocrine, that are brought to our attention. We are an advocacy group as well as a group that supports policy and planning. The diabetes model of care has been a major body of work that the Diabetes and Endocrine Health Network has been working on over the last couple of years. It was actually released at the end of 2008, and we're now into an implementation phase. This is the document itself. I'm not going to bore you. It's a bureaucratic document, but there's quite a bit in this document which I recommend that you have a look at. Now, the document is electronically on the Diabetes and Endocrine Health Network website, and that site is www.diabetes.health.wa.gov.au, along with a lot of other information that I think some general practitioners will find worthwhile. I'm going to talk in a moment about the website in particular, but that particular document, the Diabetes Model of Care, which is a comprehensive plan for how to deliver diabetes services across the state, from prevention through to palliative care, if you want to call it, right across the healthcare and continuum of care. One of its major objectives is to integrate primary health care with hospital care, and also to provide a stronger emphasis to primary health care, because that is the most effective care. If we can keep people out of hospital, that's the ultimate aim of the diabetes model of care, is to address people's diabetes or endocrine health problems before they become severe. And of course, diabetes is a classic case in point of a progressive disease that, if it's well managed in its early stages, then a lot of complications and serious health issues can be avoided or at least minimised. The important ingredient relating to the diabetes model of care is the GP is definitely seen to be the key health professional at the primary health care level, who is seen to be the key coordinator of care at primary care level. Some of the specific objectives of the model of care include increasing the capacity of GP coordinated multidisciplinary services, and that really means to enable the diversity of community-based services that need to work with general practice to provide the patient with a more comprehensive care, so that the job isn't always up to the GP to do it all, and there is other health professionals available and out there that can work with the general practitioner to provide a more comprehensive level of diabetes care. That will include dietitians, diabetes educators, Aboriginal health workers in particular. If a GP has a particular concern about local services or the lack of, the first place to go is to the local service agency, whether it be country health services or whether it be the local public health unit, whichever is most appropriate in the first instance. If they feel that they're not getting anywhere, or it might even be an Aboriginal health service as well, which is more Commonwealth, of course. If they feel they're not getting anywhere, then of course, then we might then be another way of trying to precipitate some progress in improving services at the local level. So from that perspective, we become an advocacy organisation. So that would mean any particular GP would need to bring the issue to our attention, and we would consider it as whether it's something that we can provide support and advocacy for. The Diabetes and Endocrine Health Network website is a site that has been around as a department, as part of the Department of Health websites. It's a site that's been around for some time. It's a very user-friendly site. It has linkages with other useful sites. Probably the most significant component of the site is that it's a local site. It's a site for WA, it's a site for WA health professionals, it's a site for WA health consumers. It provides information on diabetes services within WA. It provides information on diabetes planning and resources within WA. What could be of particular relevance to general practitioners is it also covers a dedicated area for health professionals. That includes the provision of clinical guidelines, clinical resources. There are various resources that are produced by the health department. One of them, for example, is the Diabetes Management Book. This is a resource that has been well used across the state by I think some general practitioners, but certainly is very well used by diabetes educators. It's a record of, for the person with diabetes, a record of their visits. It's a record of their status, their diabetes status, and enables them to keep track of their progress and keep track of their condition. If it's well managed by both the person with diabetes, if they're well looked after by the health professional, there's many people in the community that can benefit by good management of their diabetes, and of course it's also very preventable as well. So the work that we're doing with the diabetes model of care and its recommendations is very much to try and avoid the serious complications that occur with this very serious illness that's affecting something like I think 1 million Australians now are affected by diabetes. So it's one of the significant health priorities for this country, because it's also associated with the development of cardiovascular disease, which is a major disease state. It's associated with development of serious renal disease, and so to better manage diabetes is certainly one of the huge priorities for this department.
Well, that's all we have time for tonight. Don't forget that if you'd like to review this program or any previous program, you can now watch them online or download them as podcasts via the Rural Health West website at www.ruralhealthwest.com.au. We're back again on the 6th of July with a program on rheumatology. So if you've got any questions, please note them on your evaluation forms and return them to us as soon as possible. Liz and Mark, thank you so much for being here. It's a very interesting discussion. Do you have any takeaway pearls of wisdom for our overworked country GPs?
No, well, I suppose to me the important message to them is call. So we have nurses on the phone from sort of 9 till 5, really experienced diabetes educators on the phone who will take calls and give advice on the spot. And we have an on-call medical service 24 hours a day. So if there's a question, sometimes the quickest way is to call and get help. We're very happy to give advice and support GPs. So.
Right.
And yeah, so thank you. I guess the one message in regard to type 2 diabetes in children is that, that it's not highly prevalent, but of course there are certain children that have higher risk factors, and we talked about those, and it's, if you've got an advice, call.
Olga, thank you as well, and good luck for your forthcoming strutting on the boards.
Thank you, Jerry.
Look forward
ACES
to
and Galatea, 23rd to the 28th of June.
Okay, if you're in town. And thanks to you for taking the time to join us. Until next month, I'm Jerry Gannon. Thanks for being with us.